Il me fait plaisir de vous présenter notre conférencier invité de ce matin, David Butler-Jones, médecin hygiéniste en chef à la Direction générale de la santé des Premières Nations et des Inuits de Santé Canada. Dr Butler-Jones a été le premier administrateur en chef de la santé publique du Canada de 2004 à 2012, période durant laquelle il a notamment assuré la gestion nationale de la pandémie de grippe H1N1 et mis en place la production de rapports annuels sur d'importantes questions de santé publique. Il est aujourd'hui professeur à la Faculté de médecine de l'Université du Manitoba et professeur clinicien au département de santé communautaire et d'épidémiologie du Collège de médecine de l'Université de la Saskatchewan. En reconnaissance de ses impressionnantes réalisations en santé publique, la Faculté de santé de l'Université York a accordé au Dr Butler-Jones un doctorat honorifique en droit. En 2010, il a reçu le prix Robert Davies de Fries, la plus haute distinction de l'Association canadienne de santé publique. Dr Butler-Jones a également obtenu en 2014 la médaille de service de l'Association médicale canadienne en reconnaissance de son exceptionnelle contribution à l'avancement des soins de santé au Canada. Aussi, l'Agence de santé publique du Canada a annoncé récemment la création d'un prix de leadership en santé publique en son honneur. Aujourd'hui, Dr Butler-Jones nous entretient sur un sujet tout à fait d'actualité, la santé publique au centre de l'intérêt public. Dr Butler-Jones, if you please.
Bonjour tout le monde. C'est mon grand plaisir d'être ici. C'est la première opportunité depuis mon crise cérébrovasculaire pour visiter à la JASP. C'est une bonne chose pour moi et merci pour l'invitation. Je regrette que mon présentation est en anglais. Si vous avez les questions en français ou en anglais, mais maintenant, dans mon présente position de semi-retraite, d'activité de réhabilitation et les choses pour faire une assistance pour les divisions qui ont la responsabilité pour les Premières Nations. Je n'ai pas l'accès de la traduction pour mes présentations. C'est seulement en anglais. Je regrette. The health of the public is the foundation upon which rests the happiness of the people and the welfare of the state. Benjamin Disraeli, who was Prime Minister of the UK in the early days of public health, was able to say this, and it's equally true more than 150 years later. The definition that I use for public health refers to the organized efforts of society to improve health and well-being and to reduce inequalities in health. Sometimes you'll see a number of different variations on this, but this is actually my preferred one when I speak, though sometimes they're more challenging to have it in writing. And the functions, as you know, it's laid out in the agency's legislation. It's also laid out in work for many things that we do in Canada. In the United States, there's actually 20, but in Canada, we rolled them into 5 and then 6. Clearly, population health, understanding why people are healthy or not, and how communities function or not, getting at the causes of the causes. Surveillance, understanding what's coming, why, how we can change that, how we can prevent future illnesses and challenges and injuries. Health promotion, I don't need to describe that in this audience clearly. Disease and injury prevention, health protection, and certainly since SARS, a greater focus on public health emergency preparedness and response. The question is, whatever happened to, these are all les phrases anglais, colloquiales qui décrit une situation pour l'importance de la prévention. An ounce of prevention is worth a pound of cure. Stitch in time saves 9. Anything worth having is worth waiting for. Pay me now or pay me later, said Mr. Goodwrench in terms of car maintenance. Wear clean underwear in case you get into an accident, which was my mother's and I think many other mothers' And I really appreciate it if afterwards, if somebody sends me an email, if you have similar, les phrases en français, c'est pour mon éducation. In the 18th century, Jean-Jacques Rousseau said, without challenge, 1/2 of children born die before their 8th year. This is nature's law. Why try to contradict it? This is a little kid that I met in Kosovo after the war. He has, most of you would recognize, disseminated meningococcemia. At that time, in Pristina and Kosovo more broadly, which was the legacy of the Soviet system, what do you think public health's major focus was? In order to satisfy the bureaucracy, you had to get your statistics right. So it was about reporting the number of cases and deaths was the focus. It wasn't about figuring out why at that time they would have as many cases of meningitis in 1 week as we in Canada for the same population would have in 5 years. Beware losing the focus on public health. But Rousseau could say this because actually life expectancy at birth hadn't changed since the Bronze Age in his era. By 1900, it had only actually increased to 50, and 1 out of 5 babies died in Canada. So over the last century, we've actually added approximately 8 hours for every day. So if you're born tomorrow, you can expect to live 8 hours longer than if you're born today, on average. Not that we can sort of plan which parents we're going to have or anything. But it is, when you think of it, a remarkable achievement. And this just illustrates sort of the progress in infant mortality. And the reasons are pretty basic. Improved nutrition, adequate housing, smaller families, sanitation, clean water, pasteurization and immunization. Clinical services, clearly being a part of it, but actually in the big context of things over the last century, it's actually been a smaller part. And things like immunization, which I'm always amazed that there's still a debate about fluoridation and immunization. But immunization is actually, from a health standpoint, from a medical standpoint, probably the safest medical intervention, even safer than most of the things we buy over the counter and don't even think about taking. And yet we have all this debate and fear about immunizations. And when I was a kid in the 50s, hospitals, every hospital, not just children's hospitals, had huge children's wards, with the children suffering the consequences of the side effects and the endpoints of a bunch of natural diseases that now are gone because of immunization or severely diminished. And just to give you one example, if it weren't for polio vaccine, all the orthopedic surgeons in the world that we could train would not be looking at hips and knees, they'd be dealing with post-polio effects. And if not for the epidemic of obesity, we would not have any lineups for knees and hips because some 80% of the requirement is based on excess weight. And if not for war and poverty and marginalization and all the challenges in many of the countries of the world, we would have actually eliminated polio as we've done for smallpox. So it's all connected. But these simple measures actually have profound benefits. So if you look at the rate of typhoid fever, for example, in Toronto, following the introduction of pasteurization as well as chlorination of the water supply, it was dramatic. And the same over time. Now, these are not medication interventions with tuberculosis. These are social interventions in terms of improved housing, understanding about social distancing, hygiene, and et cetera, as well as better nutrition and generally better quality of life. But so often it is, as in this case, rub this on everything within 50 feet of your house. The therapeutic response. The thing is, though, if you actually look at trying to, I used to use a slide that showed when you look at different countries and you control for the economy, the more doctors you have, the higher your infant mortality. It's not that doctors cause baby deaths. It is that there are so many other factors that it really is not directly related to health services. In fact, for a long time, some of our worst infant mortality rates in Canada have been within walking distance of some of our most sophisticated children's hospitals because of poverty and all those things that you know. And this is just looking across provinces in Canada. And again, there's no direct relationship that you can associate between how much we spend on health services, what our GDP is, how many MDs we have, and infant mortality. So it's something deeper. It's something more fundamental in terms of how we organize these services, how we focus on the spectrum, which is not just about treatment and care. So William Osler, who grew up in southern Ontario, taught here at McGill as well as Johns Hopkins, was probably one of the greatest physicians of the last century. He would say, to prevent disease, to relieve suffering, and to heal the sick, this is our work. And I don't think he put that in that order by accident. I mean, given the choice between recovering from bypass surgery and not needing it, most of us would prefer not to need it. So to the extent that we can prevent, we need to do so. And then there will always be the things that we cannot effectively treat or care for, and we need to provide compassionate support and care for the quality of life. And then we actually need to do healing when we can, obviously. This is just sort of comparing, because we know there's a gradient in terms of wealth, et cetera, but if you look at this, the graph, basically if you look at infant mortality, which is probably one of the best surrogates for general health of a population, in England and Wales, over the class differences are pretty striking. Sweden was able to mitigate those differences. So there are some things we can actually do to sort of get around that notion that the poor will always be with us, they will always be poor, and they will always be unhealthy. So are you eating properly and getting plenty of exercise? So this is one of the things I find striking is, now this is a slide I used to use many, many years ago to sort of make the point in terms of how we educate. You know, one of the things we worked with some local school boards was having things in curricula around health that weren't part of a health curriculum. In other words, rather than in math class doing graphs of bauxite production in wherever, in Indonesia, we would have actually the students graph things that have health relevance for students. So one of them is, for example, looking at if you take a group of 15-year-olds and what they're going to die of prematurely, i.e. before the age of 70, you see there tobacco on the far left, motor vehicle accidents, alcohol, suicide, still significant, smaller, murder, hantavirus, and then Ebola, at least currently in Canada and in the future in Canada. What's happening in Africa is a terrible tragedy, but it is a fundamental function of poverty, marginalization, disruption, inadequate services, and an illiterate population, and inadequate response early on that allowed it to happen. It will not spread in Canada. I mean, you might get a case imported into Canada, but it's not going to spread further because these issues are basic. And then on the prevention side, just to use one example of heart disease, this is some data that was pulled together a few years ago, and basically on average in the United States, if you dropped fat intake by 1% on average, it would result in 32,000 fewer heart attacks and a significant financial savings, certainly more today. At the same time, we used to talk about there are 5,000 Americans who died of bypass surgery that they never actually needed because medical therapy would be more appropriate, but the incentives are for the quick fix and surgery. Exercise, this is actually if you provide the basic equipment like running shoes and a basketball or whatever, and people actually had daily activity. The quality adjusted life years, so that's one good year for one person, be on average about 11,000. Cholesterol meds somewhere between 38,000 and 250,000 for 1 year for one person. Coronary bypass, 20,000, beta blockers, cheaper, but you think of the impacts and why do we make certain choices and not others? Why is it that we have all these drugs of benefit, but more marginal benefit covered by drug plans provincially, and yet vaccines, we struggle to get new vaccines even though their cost effectiveness, cost benefit, and quality of life improvement are substantial. So I've got to Omer, a strange feeling like we've just been going in circles. It is about balance. It is not about one or the other. I use this as a metaphor for the health system. So, It's not that long ago. Actually spent a little bit of time in the Dominican during the 500 years celebration of Columbus. That's a long story, but I'll tell it another time. Just in terms of indigenous peoples of that island were very quickly totally wiped out, so there aren't any more, among other things. But anyway, so Columbus, he traveled into the unknown. He found the wrong place. He was looking for India. He named the wrong people. He called them Indians because he thought he was in India. He introduced unintended consequences in many ways, not just in terms of colonialization and all of that, but basically the population of the Americas was decimated by 90 to 95% within 200 years. In other words, those wonderful infections, because we used to live with lots of domestic animals and share their diseases, and then we introduced it into novel populations so that between smallpox, tuberculosis, measles, on and on and on, influenza, etc., the vast majority of the population. And if not for those diseases, if they'd had sufficient diseases to share with us, like Africa, the distribution of population would be much more indigenous and much fewer of European and other nations' extractions. But he still became famous. Go figure. So, some challenges, shall we say, in policy, because everything does happen for a reason. It's not necessarily for a purpose, however. And understanding that distinction is important. It's important also, in my belief, to avoid false dichotomies between public and private. I remember when the late Jack Layton, rest his soul, would talk about, if he'd known that the Shouldice Clinic was a private clinic, he wouldn't have gone there for his hernia operation. Well, the Shouldice Clinic operates within the system, does not charge any extra from what they get paid by the Ontario government, like anybody else, and they do hernias better than anybody else in the world and safer than anybody else in the world. Why wouldn't you go there just because it's a, quote, private clinic versus something different? It's not about the funding. It is about how that's managed and how we assure that people actually have appropriate access and the best access to care, for example. Between clinical and public health, the lines sometimes are fuzzy because you want, in clinical medicine, people be doing prevention and health promotion as part of what they do, not the other way around. And we do in public health, some clinical services, et cetera. So again, trying to make that, we need to understand those distinctions, but on the basis of the kind of work we do and the kind of focus we bring. But the fact is that we want the public and all practitioners to be as preventive in the way they do their practice as possible. Domestic and international. I used to, I've never won this debate, but at the Canadian Public Health Association, because there would always be a group of sessions around international. And I say, you want to have it as part of your regular sessions, because it's not like we do international work over there and we do domestic work over here. And I remember actually when I was doing the specialty training and I worked in the tropical disease clinic on my spare time, and the professors said, why would you do that? Why would you waste your time working in the tropical disease clinic? Public health is international. If it's not international in a context of thinking about what's happening around the world, we can't actually do what we need to do locally. And it is ultimately locally, but it's in a context of everything else. And policy and practice. Practice needs to inform policy. Policy needs to inform practice. And the focus ultimately has to be on the healthiest population for the resources. We need to be thinking in terms of, if we have X dollars to spend, what will give us the biggest bang for those resources in terms of prevention, promotion, treatment, and care. But we don't do that analysis very often. Otherwise, we do a heck of a lot more in public health. And the budget in public health wouldn't be 1 or 2 or 3%, but more like 10%, depending. It is something which, how can I put it? I'll just give you one example. For example, when it took me 3 years to get pneumococcal vaccine in the province of Saskatchewan. The cost of the vaccine and to catch up on the cohort of seniors and those with underlying risk problems would be about $500,000, and then it would be a much smaller cost ongoing. We were spending, we calculated per year, just in hospitalization for pneumococcal in seniors alone, $1 million a year. The number should be obvious, but of course, vaccine was in the public health budget, so it's a big part of a public health budget, but a tiny part of the clinical budget. And because we separate those and we think about those separately, it took 3 years to get to the point of actually funding something, and for many jurisdictions it took even longer. And health has inherent worth, however achieved. It's not about the debate in terms of, I can't count the number of times I've been in a debate where with clinicians and others, and they say, well, if you prevent things, it doesn't save any money because people just get older and they collect their pensions and they keep going back to their doctor. And I say, why the hell did you treat my pneumonias and asthma as a child? Because I survived. You know, like, and I'm going to the doctor. Even now I've had a stroke and I've had immune problem, and I'm costing the system a lot of money. You should let me die. But if it were treatment, it's okay. That's just bizarre, if you ask me. It's a little bit, anyways, we'll maybe talk more about it later. So bad policy, and we see this unfortunately too often if appropriate public health approach is not brought. And the question is that we all face as governments or other organizations in terms of policy. So there's a problem. It's a big problem that something actually has to be done about it. And then, well, this is something, let's do this. So we can, I don't know, so we can say we're doing something. It's why we ended up with temperature screeners during SARS. It was a total waste of money and time. And a false sense of assurance that probably actually increased the risk. Because people go through the screen, well, I had my screening, and the fact that they get sick a couple days later, well, couldn't have been SARS. It's the same thing with universal precautions, right? Where if you label people, it actually increases the risk to health practitioners because human nature, we're more careful with those that are labeled and less careful with those that aren't labeled, even though most cases we don't actually know whether they have it or not because most of it's asymptomatic. So anyways, and we could talk about Ebola more, but we'll leave that to the current policymakers. The best policies and the best practice, in medicine, one of the first dictums is first do no harm. In other words, don't make it worse. So the rush to intervention creates problems and side effects that really aren't warranted. So what you want ultimately, whether it's in a policy or in a practice or a therapeutic, is you want the least intrusive, the most effective, with the fewest side effects. And it's about weighing all three. It's not just whether it's effective or not. It's not just whether you can sort of have a choice or not, etc. It is really about the combination of those, and it's always a debate, and it's always a balance. So this is just a graph that I used to illustrate the relative costs. SARS was actually a small problem, but a huge economic challenge and a huge challenge for government and policymakers in terms of trust that governments are actually doing what they need to do. And it did give rise, I mean, the silver lining, the terrible thing was the 42 deaths and those who were affected both directly or indirectly in Toronto, particularly the individuals and their families. But outside of that, Toronto was actually probably the safest place on the continent. Because people were staying home if they were ill, and they were washing their hands like crazy. And you could get into any theater, any restaurant, any hotel you wanted at cheap rates. So why would you cancel your conference? Because really the only risk was in the few hospitals that were affected, and even there, when they paid attention, the risk was substantially diminished. Pandemics. A few in this room were chief medical officers at the time. Andre, Alan, myself, and I don't know who else is in the room who were provincial or federal chief medical officers at the time. But I just want to say congratulations to you and your colleagues across this country, because Canada actually did, don't quote me if there's any media in the room, but it's true. Canada did better than anybody else in the world in terms of, for the first time in history, we actually fundamentally altered the course of a pandemic. And people say, well, what was the big deal? It wasn't that nasty a virus. Well, the reality was we have in our lab, and the Americans in theirs, different strains that kill ferrets, which are the best model for human disease, faster and nastier than our 1918 virus. So the virus was essentially the same, but our abilities, the health, the general health of the population, our capacity to respond, our understanding of infectious disease and transmission, the social distancing, coughing in sleeves, the washing of hands, the gels, the immunizations, the antivirals, which actually worked. And so we actually selected for less virulent strains that then spread around the world. And some would pop up with more virulent strains periodically, but in Canada, we stopped the pandemic before Christmas. No one else can say that. In the United States, they continued through the spring. In Britain, it came back the next fall and the next winter and filled up their ICUs once more. And if not for those measures, it would have, if the world was the same as 1918, the pandemic would have looked the same as 1918. The other thing to note is 1918, that acute viral infection, that healthy one day, young adult one day, dead the next, we saw a lot of those in Canada. Fortunately for many of them, we have ICUs and ventilators which are in a position to actually keep them alive long enough, whereas previous they would die. So rather than 100% mortality rate in those, it was around 10 to 12%. At the same time, when you look at the difference between 1918 and the 50s and 60s, in 1918, 90 to 95% of the deaths were due to secondary pneumonias, not that primary acute viral overwhelming infection. They had no antibiotics. They had no ways of treating that. The 50s and 60s, they had antibiotics. Now we have substantially more ability to treat, but also to understand and prevent. Striking how, we sort of get concerned about, programs in terms of how do you change behavior about sort of things, but people in Canada coughed in their sleeves and washed their hands like crazy during the pandemic. And still you see kids coughing in their sleeves and learning how to do that rather than coughing in their hands and sharing diseases and rub my nose, shake your hand, you rub your nose, I get sick tomorrow, you get sick the next day. What it was an important issue, a simple measure that anybody could do. And it's like in risk communications, I say, what do we know? What do we not know? What are we doing to find out? What are we doing to address it? And just as, if not more important, what can you do to protect yourself and your families and friends, etc.? And so when you put that together, people will change their behavior. So for the agency itself, when we set it up, there were basically articulated three priorities, and you would see this through our various planning documents, etc. And one of the things that I said at the outset was public health is local. People get sick locally, they are well locally, they interact locally. The job at either regional, provincial, or national or international fora is what is the value added that will allow people to actually do the job. And so when it comes to the development of the agency, clearly the first priority, because if we don't handle the emergencies well, we don't have any credibility for all the rest of the stuff, is to be able to actually prepare and respond to public health emergencies. And I think collectively we demonstrated that in H1. To move health promotion, public health into the 21st century in terms of that interface between policy and practice, between social determinants and individual behaviors, in terms of understanding how we actually bring that together in a practical way, and support for public health practice. In other words, so that every nurse, every inspector, every teacher, every whatever doesn't have to reinvent constantly. We can learn from one another. And that's where Quebec has a lot to offer to the rest of the country and elsewhere. Sometimes the language barrier is a challenge in terms of traduction, etc. But my observations are that there are so many things that in Quebec the rest of the country could learn from, and we tried and worked at sharing those things. And there are things that Quebec can learn as well. But it is about that sharing that together we can actually do it better. So remember, I did mention possible side effects. So as I said, the focus has to be on the healthiest population. For whatever the resource, it has inherent worth. The greatest health does come. I mean, we recognize that historically outside of health services, but it doesn't mean that health services aren't essential and important. Without them, we would not anywhere near have the quality or sustainability of life that we do. It's not a panacea. It has both benefits and it has risks too, and we need to understand what the risks are, the trade-offs. I don't know how many of you remember when the orthopedic surgeons were pushing screening of all young girls for scoliosis. Well, as it turned out, we found very little. We couldn't really intervene very effectively. And thirdly, that now there were a whole lot of young girls who thought they were fine before, now discovered they were deformed in some way, even though they weren't. And so the unintended consequences we have to be careful about. It's not the last resort of failed treatment. Remember in the early days of HIV/AIDS, and people would say, we have to prevent it because there's no treatment. Why would you want to get AIDS in the first place? It's better to not need it in the first place. It's a spectrum, and it really is important in understanding it is a spectrum. It isn't about one or the other. It's not a competition between them. It is about looking at them as a whole and what the best benefit for the population is as a result. And it is an expertise, and a lot of people think it's easy to do, but it's easy to do poorly. And we've seen so many examples of that. I'll just give you one example. Doctors for Smoke-Free Canada, I can't remember what we used to call ourselves now, back a while ago, but got some money to do these ads. They were really slick. I don't know if you had them in Quebec, but they're in Anglo-Canada. They're super slick. They're great production values. They had graveyards. They had operating rooms. They had, an announcer that was very overwhelming, and all the ex-smokers and non-smokers said, yeah, that'll convince them. And somebody was smart enough to actually see what the smokers did, and what the smokers did was smoke more, because it increased their anxiety. It didn't give them out. How do they deal with their anxiety? Well, they smoke more. You get upset about your obesity. What do? You have more ice cream. It is about providing, and that's when in Anglo-Canada we saw the ads change to someone chained to a cigarette, and we can help you break that chain. So we have to understand exactly what it is we're doing. And quite honestly, I was surprised when I was getting quite frustrated. And this is in the agency. It's telling stories out of school. But I was getting quite frustrated in the agency because some of our health promotion efforts, I thought we'd given up sort of a decade or two before. And I asked the director of this division of several hundred people, so how many people actually have training and experience in health promotion? And it was like 5. So no wonder, we don't have the experience and background to actually bring a quick solution. So whether it's not just about avoiding disease, it is about pursuing health. It's about building our communities, arts and music, and the interplay between the social and the physical. Having an active lifestyle, whatever our abilities. It's not about everybody becoming joggers. Volunteerism. Volunteers, people who give themselves, are healthier. Funny thing. Friends and family. There's two things, so when we talk about social determinants, there's two things that everything else, you put together, but there's two things I would observe that make the difference between okay health and really good health. The first is that you actually have a sense of control over your future, that what you do makes a difference to your future health, well-being, or whatever. That's why most of our welfare systems are dysfunctional, because they create dependencies. They don't actually allow people to make decisions. If you make decisions to improve your lot, you end up having to lose your welfare, etc. The residential schools, the reserve system, on and on it goes. The other is that you have people that you care about and people care about you. Doesn't matter what age, male or female, people who are well connected have half the risk of dying of those who are not connected. So whatever else we do, we have to address those. So I'm just going to finish and leave some time for questions, right? Because we've got till 9:30. Having chaired a lot of coalitions, and I learned last night the notion in Quebec sometimes of coalition is a little different than I think of coalitions. I think of coalitions of groups that come together for common cause. And whether it's interprovincial or intergovernmental or interjurisdictional or interdisciplinary or NGOs or volunteers, whatever it is. When I'm talking about coalitions, I'm talking about any kind of formation which is a voluntary formation to get together to actually accomplish something. And having done that for a number of years, there's a few things that I've learned the hard way. Up in the top left corner, partner, enable, cheerlead, mitigate, advocate. That's a frame I use to talk about, I won't go into it today, but when I talk about the social determinants, and sometimes it just seems so overwhelming. What can we do about poverty? What we can do about, and really it is the point, and my reports have been focused not just identifying once more why the poor or First Nations or Aboriginals are less healthy, but what can you do about it, either at the individual, community, organizational, policy level, not as a compendium, but as ways of thinking about this. And then we find that there's actually lots of things that we can do, either individually or collectively. But in order to actually get there, one of the things that is absolutely essential is we have to respect who we're trying to deal with. Because you cannot respect who or what you don't, you cannot influence who or what you do not respect. And that's, you don't have to want to go to dinner with them, you don't have to even like them, but you have to respect who they are for who they are, what they're doing, what their responsibilities, etc. And if you can understand that, then you're more likely to have influence. I remember back in the 80s and 90s, and I go to conferences, and then people talk about advocacy, and they'd say, have your 15-second speech ready so when you're in the elevator with the minister, you can get it out there. And I thought then, and I would say now, what you should say is, hello, I'm so-and-so, this is what I do, it's a real pleasure to meet you, I hope you have a fine day. Because you start your harangue, and having been a senior bureaucrat, both provincially, federally, and locally, we go to our happy place. You know, it's kind of like, I remember in Ontario, the NDP, it just felt like the way they dealt with problems, they put all the stakeholders, call them stakeholders, in the room, and you bang each other over the head, you see what emerges, and that'll be the policy. It is not about haranguing others into getting them to think the way I do, because where do I go? Where do we all go when somebody's haranguing us about how stupid we are and how brilliant they are, and if only we'd wised up to their wisdom, the world would be a better place. No, it's about a conversation. It's about how can I help you solve your problems that will also solve my problems or address the issues that we're trying to address in the community. So respect is fundamental. Making it practical, not just about somebody needs to do something about something. It is about, well, if we could do this, we could accomplish that. It is about how you can actually make something workable. The third is the rule of three, particularly in coalitions or intersectoral, intergovernmental work. And it's something that I think we tried to apply effectively in the Public Health Network Council. And that is, what are the things, first of all, what are the things we can agree on? And let's get on with those. And then there are the things that we may not think are perfect, but we could live with. At least get on with those. And then there'll be the things we will never agree on. Don't spend all of our time and energy trying to convince somebody else of something we know. I mean, there are just some things that a certain provincial government or the federal government just isn't going to go there. And I may agree, and I may think you're right, but the government's not going to go there. So why spend our time haranguing each other over that? So find the things that we can actually get on with, and not ignore the 5% we'll never agree on, but not spend all our energy focusing on that and focus on the things we actually can do proactively. And then have something to offer. I can't count the number of times where I go to another deputy and there's something that's circling and nobody has full responsibility or resource or accountability or the ability to do it. But I say, well, if I could do this, could you do that? And if you have something to offer, then suddenly it's a whole new conversation. It's like trying to get environment to include health as part of their environmental assessments in Saskatchewan. And they're like, oh no, we've got enough to do and you guys already have all the money. But then I said, no, we will do that part of it with you if it would be helpful. Oh, well, that's a different conversation. And then the other pieces are just, well, you probably had a chance to read them. At the end of the day, I really wonder what expertise, though, we don't need. I'm constantly learning. There are just, from anybody and everybody, and even within the same discipline, there's just so many levels of expertise and understanding that we can gain from. And we have 5 minutes. Okay, I went backwards. There you go. So, I'm ending with, I'll have an ounce of prevention. Merci encore.